Dr. Raina Letourneau. I'm the Executive Director of the Florida Center for Nursing and an Associate Professor at the University of South Florida College of Nursing, where the FCN is proudly headquartered. Thank you for joining this webinar. The goal of this webinar is to take a deep dive into the methodology of the research used to create the report, Florida Workforce Projections 2022-2037. The Florida Workforce Projections 2022-2037 report offers a macro view of the state's healthcare workforce in order to provide context for future strategies. We partnered with Global Data to increase the scope of this report and leveraging their expertise in workforce modeling. So please allow me to introduce you to my colleague, Clark Ruttinger. Clark is a healthcare workforce policy researcher with a demonstrated successful history of conceptualization, implementation, and management of complex long-term data-focused projects. Clark is a director at Global Data and served as the lead for this collaborative work. And I'd also like to introduce Patrick Zarek from Global Data, who also contributed to this project, developing projections. Let me please turn it over to Clark to discuss our deep dive of the research.
Thank you, Raina. Thank you for the opportunity to take a little bit deeper dive into the project we've done for you and go over some of the assumptions from our modeling. This information is included also in our report. It's always good to have an explanation of the deeper details of it. So we're going to go through an introduction of Global Data and our health workforce consulting team. A little bit of an overview of our demand model and our supply model, and then really get into the details of our supply methodology, going over how we got new entrants, hours worked, and attrition patterns, and then some concluding remarks. So famous British statistician George Box, he says all models are wrong, but some are useful. And this is certainly a useful model. We've designed it to be able to allow for synthesizing a great deal of complexity from multiple data sources so that it can be understandable and used for long-term strategic planning. We are able to produce scenarios to test out what-if situations that may happen into the future. This is also a transparent model. It's not a machine learning model that is a black box. We know what the inputs are and the resulting outputs if you change those inputs. And so we'll go over a little bit of that detail today. But it also, I think, encourages proactive policy, meaning that you know what is going to happen in the future if you don't act. And you also know, to some extent, what might happen if you do change things. So some might critique models in that they're too simplified. And that is true to some extent. We can model things down to the county level with this data, but we don't know what's happening with individual health systems necessarily. But again, this is a tool to clarify what's going on a macro level. This is backwards looking in that we're looking at data from the past, but frequently the most reliable predictor of the future is to look at the past. And so then obviously it doesn't account for unknowns like shocks from a pandemic or other things that might be unplanned. And there are constraints in that, we use data that's available, but we have very good data from the state of Florida from a variety of sources. And we hope to avoid the last critique in that we're providing additional interpretation of this report and the findings so that it won't be overinterpreted by policymakers. So we do a lot of work with the federal government, the health workforce, the National Center for Health Workforce Analysis. We produce projections for them. When you go to the HRSA website and look for how many nurses there are, that is our work. We also produce projections of the physician workforce nationally for the AAMC. And we've done many studies with professional associations across the country, most recently with the American Physical Therapy Association. So we use that information and the experience from that modeling to influence the modeling that we do on the state level as well. We produce state workforce studies for several states, ongoing work with the Florida Center for Nursing, also the Texas Department of State Health Services, recent work in the University of Hawaii for the state of Hawaii, Maryland, previous work in Vermont and Georgia. Many times we're working with hospital associations in these states to create a projection and then help them develop their policy recommendations. And so we've done lots of previous work in the state of Florida with the Florida Hospital Association and the Safety Net Hospital Alliance of Florida. We continue to do work with them. We'll be producing new work with physicians for the Safety Net Hospital Alliance. And we've just recently done a series of allied health professions, not the same ones that we've done for FCN, but a series for the Florida Hospital Association. And so that work helps to inform this work as well. Ongoing other work with several state hospital associations, though, with Kentucky, Maryland, Arkansas, Tennessee, and others. So our modeling uses what's called microsimulation. Microsimulation is a technique that simulates the behavior and outcomes of individuals in a given population. So we're measuring specific people and their interactions and decisions. So in supply modeling, we're measuring the probability of individual physicians or other health professions, the probability of them remaining in the workforce based on their demographics, their specialty, and their work patterns. With our demand modeling, we're measuring the probability of individuals utilizing healthcare. And then in both situations, we're projecting forward growth and changes in those populations. So this differs from more simplified models, stock and flow models, in that we're not treating groups as cohorts moving through a model. We're actually modeling the individual probabilities of each person in the model and how they interact with each other through the model as it's projected forward. Often when people model demand, they simply take a population to provider ratio and they extrapolate that forward. And so we're not doing that here. Here we're actually drawing on data that describes actual utilization of healthcare services in the population. And then we're projecting forward that demand based on population demographics as they grow into the future. So again, microsimulation is useful because it captures real world variation and interactions between behavior, demographics, and decision-making of individuals. We also can produce detailed scenarios to show what happens if things are changed, such as if GME is expanded or more nurses are produced or there's increased retirement. It improves precision in planning so that we know, what is going to be happening in the near term and in the long term. And then we can produce different forecasts based on different variations in scenarios. So technical documentation for this modeling process is published in detail by the federal government, and the same model is used for this work. And so you can search for that by searching on the HRSA website, their health workforce projection documentation, technical documentation. So going into our demand modeling overview. Again, we use a microsimulation model, and we start out with a population of a representative of the target population for the state that we're working in Florida here. We derive healthcare utilization patterns from the Medical Expenditure Panel Survey, which is a national survey on healthcare utilization. And then we also translate those healthcare utilization patterns into demand by setting and specialty. And then we can model multiple different specialties and providers. Here for FCN, we've modeled 13 different providers. And we'll go into detail on each of those in this presentation. So for healthcare service utilization, we're starting off with the Medical Panel Expenditure Survey, which is collected from AHRQ through the federal government. We use various demand modeling data sources for describing the Florida population, national surveys with Florida subsets, including the American Community Survey, the Behavioral Risk Factor Surveillance Survey, minimum nursing home and Medicare beneficiary surveys, so we know who are in those parts of the population. And then we're also drawing on census and CDC data on demographics, age, sex, race, and ethnicity to describe prevalence of conditions and health risk factors, as well as population information and projections directly from the University of Florida's Bureau of Economic and Business Research. So we construct a population file, and it contains all of this information about everybody in the Florida population. And we use this data to create a predictive model to describe utilization in the population. So if you plug my demographics in there, you can accurately predict my healthcare utilization. If you plug Raina's demographics in, then you can accurately predict her healthcare utilization. And then we can translate that into first providers required to provide those services, and then into growth into the future. We produce some scenarios from that projection. The first one is applying the national patterns, or the average predicted amount of care use by the demographic patterns in the population and the staffing, how things will grow without intervention, called the status quo scenario. So this accounts for Florida demographics and health risk factors and aging in the population as the projection moves forward. It includes adjustments to the Florida population where we get new population estimates on a regular basis. And then we also produce an alternative scenario that we call a reduced barrier scenario. And this assesses the demand for healthcare workers, assuming those in the model that don't use care at the highest level, which is the individuals in the model with the highest care use patterns happen to be the insured, non-Hispanic, white individuals living in metro areas. So if everybody uses care at that highest level, then the reduced barrier scenario describes what care would look like, what demand would look like. So moving in to describe some of the data that we have used for our modeling, this is a comparison of the US and Florida population growth over time for the projection period. So we see here that in Florida, we actually have quite a different story from the US average, in that the population is projected to be growing faster in every age group than it is in the US. And so this has implications for both the workforce and healthcare demand, in that Florida in specific will into the future have individuals to draw on to bring into the healthcare workforce, because they have individuals under 18 that are growing and individuals that are just starting to be in the workforce that are growing. Conversely, the US overall doesn't have as much growth in these areas. Other states have negative growth in some of these areas. On the older end, though, population is growing, above the age of 75 at a very strong growth rate over the projection period. So that has implications also for utilization of healthcare, because older individuals use more healthcare. So again, looking at this same data, expected population growth by region, your highest growth regions over time are going to be the East, Central, and Southwest, maybe followed by the Northeast. So this can be matched with projections of the workforce and demand that we've produced in our reporting to see how that demand and supply grows in comparison to the population. So this data comes from the CDC and is describing health conditions and risk factors by region across the state. So you'll notice here you can compare to the US average and the Florida average. Looking at these things regionally, some of the things that might jump out are a little bit higher diabetes rate in the Southwest, higher rates of arthritis in the Southwest, higher rates of obesity, maybe in North Central. So you can see, though, that these rates and risk factors do vary across the state, and we've put this data into the modeling as we model demand for services. Translating that demand into services, then we look at growth of inpatient days over time, ED days, and comparing that to population. So although Florida's population overall is projected to grow by 17% over the next 15 years, ED visits and inpatient days are projected to be growing even faster. So higher demand for ED visits and inpatient days. And this has implications for demand for providers as more services are demanded. Again, translating this utilization into looking at by setting and by age, you see that younger individuals use both emergency and inpatient days at lower rates than older individuals. As we get older, these especially inpatient days might be used at almost 5 or 6 times the rate of the youngest in the population. And so again, this is specific to Florida data and has implications for, utilization demand over time, and then the workforce that is required to provide that demand. And looking at a little more detail into the probability for utilizing services. This is an example of one of the most common types of hospital services, which are cardiology-related hospitalizations. And so this data is coming from the Medical Expenditure Panel Survey and the National Inpatient Sample. It shows odds of hospitalization for a cardiology-related incident. So we notice here that if you have had cardiovascular disease, you're nearly 4 times higher likely to have a cardiology-related hospitalization. Down on the right side there, as you look at the interpretation of this, those age 18 to 34 have the least probability of a cardiology-related hospitalization. But then we can calculate out the utilization rate for everybody in the model based on the different factors, the age, geography, income, insurance, and other factors in the model. And then, of course, this has implications for the amount of cardiologists you need, but also the amount of nurses you need. So one final thing we've done with demand modeling is we take our model as it comes out of our modeling, and then we validate it using data from claims in the state. And so we've received data from Florida Hospital Association for inpatient care use patterns in 2022. This data showed that 5.2% of 14 million total inpatient days were delivered to out-of-state patients. And so we can adjust our modeling both for demand from out-of-state patients, but also predicting the accuracy of our model for the population. It was at 92%. And so we're able to then adjust our model to make it accurate to the state data. With future iterations of this modeling, we've actually found some better sources where we can draw on data from the Florida Agency for Healthcare Administration and get detailed inpatient, outpatient, and ER claims for every year of claims in Florida into the future. So we'll be able to improve this demand validation in the future even more. So moving on to our supply modeling overview, I'm going to turn the time over to my colleague Patrick to complete things.
So thanks, Clark. So I'll begin with an overview of our supply model. We are using a microsimulation approach which means that we are building up at the individual level. The basis of our starting supply typically comes from either licensure or workforce survey data containing information on practice location, hours worked, active status, and demographic information of the health workforce. From the initial licensure data, we determine starting supply by removing individuals who do not meet certain criteria to be considered part of the labor force, such as having an inactive license or practicing outside of the state of Florida. After determining starting supply, we generate a series of predictive equations on hours worked, retirement, and migration patterns based on the demographics of the workforce. Then, as we initiate the model and move from one year to the next, we first remove individuals due to attrition. And attrition can take three forms. This can be either clinicians retiring or leaving from healthcare. They can be changing careers or moving outside of the state of Florida to practice in another state. As we enter the next year in the model, we add new entrants. And the estimate of new entrants is an average of new licenses issued over the past 3 years. And we capture the demographics of these individuals as well to be used in our regressions. Once we have determined our new starting supply, the process repeats itself as we move forward, applying the same predictive equations to determine attrition and hours worked, while allowing for shifting demographics such as age. And we repeat this process for 15 years or the duration of our projection period, which for this study is 2022 through 2037. What I was describing previously reflects the status quo scenario, which models a continuation of current trends while allowing for shifting demographics such as age. We also model 4 alternative scenarios as well, and this will capture varying conditions around attrition and new entrants. We have our early and delayed retirement scenarios, which reflect workforce decisions as if providers were either 2 years younger or older. And we also have scenarios around more and fewer graduates, reflecting either a 10% increase or decrease in the number of new providers entering the Florida workforce. Now, this is a static change, and it does not compound on itself. So to give an example, if under the status quo scenario, we had 1,000 new entrants, then under the more graduate scenario, we would have 1,100 new entrants and 900 under the fewer graduate scenario. So now we'll take a deep dive into each of these inputs at the occupational level and beginning with the process of determining starting supply. So the methodology for RNs, LPNs, and APRNs slightly differs in that we had access to both Florida licensure data and Florida workforce survey data, compared to the remaining occupations where we only had Florida licensure data available in determining starting supply at the individual level. So the licensure file that was provided to us contained all occupations in a single data set, and this allowed us to have consistent methodologies applied across professions. In our analysis, we first did some initial cleaning steps that sampled for missing values around practice location. Our methodology to determine missing practice location was to first use an individual's mailing address if available, and if this was not available, we sampled from the available practice state information by profession. So after these initial data cleaning steps, we begin the filtering process to determine who is eligible for our starting supply. We exclude individuals over the age of 75, those who have an inactive license, and those who are practicing outside of the state of Florida. Then we remove duplicate entries and individuals who are also listed as APRNs in the initial data. And so it's at this point where we join the workforce survey data to the licensure data by license number. And this workforce survey data contains information on employment status and educational background. So we are only interested in individuals who are actively practicing in a role that requires their educational background or are seeking work within that role. All other individuals who are working in a different field or unemployed are then removed from our starting supply estimate. Now, as we are using the average definition of a full-time equivalent, our starting supply headcount and starting supply FTEs are the same for a final estimate of nearly 250,000 FTEs. When comparing to other data sources, our estimate falls between the 2023 FCN report and 2023 May BLS figures. The FCN report was focused on active licenses, and the BLS is an employer-based survey, which provides a more conservative estimate using this methodology. So our process for determining starting supply for LPNs mirrors that for RNs. From the initial licensure data, which has been sampled to complete the missing values around practice location, we remove individuals over the age of 75, those who have an inactive license or are practicing out of state. We then remove duplicates and individuals who appear in the initial data as either RNs or APRNs. And again, it's at this point where we join the workforce survey data and use the questions around employment status to retain only those who are actively working as an LPN or seeking work as an LPN. And these steps lead us to an estimated starting supply of approximately 46,000 LPNs in 2022. So the initial licensure file provided by the Florida Department of Health contained a profession code for APRNs, but did not differentiate between APRN type. This information was contained in the workforce survey data, so in order to model APRNs at the category level, we did our initial filtering steps with the licensure data, and then joined the 2022 and 2023 survey data to the licensure data by license number again. This join is represented by the first gold bar in our chart, and after the join, there were approximately 25,000 matches to the licensure data, denoted by the pre-sampling APRN practice type and broken down by our 3 categories of interest. Those 3 categories being nurse practitioners, nurse anesthetists, and nurse midwives. After sampling to complete the missing information, we have a total of 43,520 APRNs and their resultant categories. Now, this figure is slightly below the pre-sampling total, as we removed certified nurse specialists as they were not part of the study, but were identified in the survey data. So the final steps to determine APRN starting supply by category are on the following slides. Starting from our post-sampling count of nurse practitioners from the APRN filtering process, we use the survey data to remove individuals who are not part of the workforce to determine our starting supply FTE of 34,000. Further questions on practice setting in the survey data allow us to break down the NP professions further by category. And we can see that the majority of NPs are working within primary care, medical specialties, or other, and then followed by surgery and home setting. For nurse anesthetists, the same process is followed. However, setting does not apply, and so after removing individuals who are not part of the labor force, we have our starting supply estimate of 5,200 FTEs. And again, starting with our post-sampling estimate of nurse midwives, we retain those who are actively practicing or seeking work as a nurse midwife to obtain our starting supply estimate of 680 FTEs. So for physicians and the remaining occupations, the primary source for estimating starting supply is the Florida licensure data. In addition to our previous steps to remove individuals who did not meet the criteria for our starting supply, we also have an indicator in the licensure data on whether or not an individual is in residency or not, and we exclude these individuals as well. And while the breakdown is not shown on this slide, projections for physicians are also done at the specialty and category level. We use our global data crosswalk to categorize physicians in the licensure data to 36 concise specialties, which are then aggregated to our 4 categories of interest. Those being primary care, medical specialties, surgery, and other. Now, a caveat to our specialty breakdown is that physician specialty is not currently a mandatory field in licensure data collection. Approximately a third of active physicians did not report their specialty information, and so this information was sampled from the available specialty pool to complete the missing entries. And further, we use AAMC estimates on hospital lists at the national level to convert a proportion of individuals within primary care to hospitalists, as this information was unavailable in licensure data as well. And so overall, we are estimating a starting supply of physicians to be nearly 62,500 FTEs. Determining starting supply for physician assistants is similar to that of physicians. However, removing residents does not apply. Our process here shows how we estimated starting supply for physician assistants as a whole, but again, we were able to break this down further for our findings at the category level using estimates from the 2022-2024 Florida Physician Assistant Workforce Survey report. So for both physicians and physician assistants, we assume that all those with an active license are part of the labor force due to the education and specialization required for the profession. And following our filtering steps, we estimate physician assistant supply to be 11,900 FTEs. For the remaining groups of allied health, pharmacy, and nursing assistants, we apply a labor force participation rate when initializing the model before determining our starting supply by headcount and FTE. This estimate is based off of analysis of the American Community Survey, or ACS, as this information was not available in the licensure data. And so after following our filtering steps and applying this labor force participation component, our estimate of physical therapists in Florida is approximately 17,000 FTEs. For occupational therapists, the initial data contained 23,000 individuals, but after following our filtering steps, we obtain a starting supply estimate of nearly 10,000 FTEs, still coming in slightly higher than the BLS estimate due to different methodologies. The majority of respiratory therapists are removed from the initial data due to holding an inactive license. In this step, we exclude nearly 20,000 individuals, or half of what was in the initial data. And following our steps and applying our labor force participation rate, we estimate a starting supply of 12,000 FTEs in 2022. So after following our filtering steps and initializing the model, we estimate a starting supply headcount of 25,640 and 25,630 FTEs. You might notice here that the values are slightly different, whereas for the previous occupations, they were exactly the same. This is an artifact on how the labor force participation component is applied when the model is first initiated and after we have already defined what an average FTE is. And so if individuals who are removed worked more hours on average than our average FTE, this will bring our starting supply FTE below the headcount figure. The converse is also true. If our labor force participation component removes individuals who work less hours on average than our average FTE, this will raise our starting supply by FTE above the starting supply headcount. And this variation is more pronounced with larger sample sizes, like we will see with pharmacy technicians and nursing assistants. So for pharmacy technicians, the vast majority of individuals are removed from analysis due to having an inactive license. This implies a high rate of turnover within the occupation and decreased barriers to entry or exit as a whole. So after applying our labor force participation component, we derive a starting supply headcount of 47,270 and a starting supply by FTE of 47,330. Again, implying individuals who were removed from our labor force estimate worked fewer hours per week on average than their occupation group as a whole. Most nursing assistants are removed from our initial data due to having an inactive license or being a duplicate entry. This again implies high rates of turnover and decreased barriers to entry and exit from the profession. After applying our labor force participation component, we estimate starting supply by headcount to be 127,750 and 127,920 by FTE. Now, switching over to our various workforce patterns, we will begin with new entrants. We derive our new entrant count by taking an average of new licenses issued over the past 3 years by occupation. This count will include both clinicians who are newly licensed to practice in the state of Florida and also clinicians who have already been licensed but have recently moved to the state of Florida and obtained licensure. Now, again, this figure is treated as constant over the projection horizon while allowing for shifting demographics such as age. On our left, we have a breakdown on the annual new entrants used for our model by occupation and education level. Our model differentiates inputs for RNs by education level, but we combine the groups to report total FTEs for the occupation in our results. We estimate that approximately 2/3 of new RNs to the state of Florida have a BSN over an ADN in nursing, and we can see from the demographics on our right that a larger proportion of those under the age of 26 are entering the workforce with a BSN as well. And this is indicating that this is a trend that will continue over time. LPNs have fewer new entrants by comparison, and as we will later see, have higher rates of retirement, both of which are factors in declining LPN supply. Our physician new entrant analysis is broken down at the categorical level. The majority of physicians entering the Florida workforce are categorized within primary care or other, and in terms of demographics, the majority of new entrants are male between ages 31 and 40 and non-Hispanic white. The APRN role has been rapidly growing at the national level over recent years, and the same can be said for Florida as well. This growth is predominantly led by nurse practitioners and may help to offset some of the shortage conditions that we have seen in other occupations. Now, when comparing the age distribution of new entrants between physician assistants and APRN categories, we see that a higher rate of physician assistants are entering the workforce below age 30 than APRNs. And this implies that PAs are entering the profession in Florida after finishing their education, while APRNs typically have more years of experience as RNs in the workforce before making the career change. For our pharmacy, allied health, and nursing assistants, we see lower levels of new entrants within allied health and pharmacists due to increased education requirements and higher barriers to entry and exit. Pharmacy technicians are seeing rapid growth compared to pharmacists, and this may help to offset some of the shortage conditions faced by pharmacists within the scope of practice, which we will cover later in the key findings. So in generating our hours work patterns, we used an OLS regression approach with sources varying by occupation. As hours worked are not captured in the licensure data, we were only able to use Florida-specific hours worked patterns for RNs, LPNs, and APRNs due to the workforce survey data provided by FCN. For physicians and physician assistants, we used data from AAMC and AAPA respectively, while the remaining occupations have their hours worked patterns derived from the American Community Survey, or ACS. But in all cases, we apply our regressions from the varied sources to the demographics of the licensure data to be representative of the Florida workforce. So breaking it down, we have RNs and LPNs. They begin with similar hours worked patterns, with LPNs seeing a large increase from early to late 30s, while RNs see a large increase around age 45. In both cases, their hours worked tend to level off around age 45 to 60, whereby they begin to enter the typical retirement age of 65 and rapidly decrease their hours worked from there on. Of all of our occupations in this study, physicians tend to work the most hours on average, and physicians within surgery work more hours than their peers. Physicians tend to have higher workloads coming out of residency, and this levels off over time. There is a tendency to increase hours worked as they near retirement age, and then decrease hours worked past the age of 60. For physician assistants and APRNs, they follow similar trends with higher workloads in their early careers, followed by decreased hours worked in their later 30s and increasing till they peak in their late 50s. From age 60 and beyond, we see a decline. From age 60 and beyond, we see a decline in hours worked as providers near the traditional retirement age of 65. Now, hours work trends tend to vary by occupation. For the pharmacy, allied health, and nursing assistants up to age 45. Physical therapists and occupational therapists see declines in hours worked, while respiratory therapists, pharmacy occupations, and nursing assistants increase their hours. Now, after age 45, this tends to flatline till around age 60, whereby all occupations have declining hours worked. So we capture attrition for those age 50 and above through retirement probabilities generated from national sources and applied to the Florida workforce. These retirement probabilities vary by age and generally increase as the provider grows older. For those under the age of 50, we apply a flat career change probability that is derived through analysis of the current population survey, or CPS, and these career change rates will vary by occupation. If you'd like to see a more detailed breakdown on this methodology, you can take a visit to the HRSA website, which provides a technical documentation on the modeling process at the national level. So again, our model inputs differentiate between retirement patterns of RNs based on education level, but we actually see little difference between the retirement rates of BSNs and ADNs here. LPNs, by comparison, have higher rates of retirement than RNs at earlier ages, but then lower rates of retirement past the age of 62. However, LPNs have higher rates of career change for ages under 50, and this leads to higher rates of attrition among LPNs over their RN counterparts. For physicians and physician assistants, we separate retirement rates by gender as we have increased sample sizes for these occupations. Further, for physicians, we allow retirement rates to go up past age 75 and are capped at age 90 due to the longer career spans of the occupation. A general trend is that female physicians retire earlier on average than male physicians. And at the categorical level, female physicians within surgery have the earliest rates of retirement, and male physicians within medical specialties have the latest rates of retirement. So again, we break down physician assistant retirement rates by gender, but we notice little variation between male and female retirement patterns. APRNs, by comparison to PAs, have tendencies to retire later, with nurse midwives having the latest retirement rates of our APRN categories of interest. Within pharmacy, allied health, and nursing assistants, we estimate that occupational therapists and nursing assistants have the highest rates of retirement, leading to the traditional retirement age of 65. After the traditional age of retirement, the rate of attrition for nursing assistants slows down relative to the other occupations. while occupational therapy retirement rates remain higher than the other groups throughout. So to wrap things up, we have provided a detailed breakdown on our demand modeling process, which uses Florida subsets of national surveys to predict current and future healthcare utilization rates based on the demographics, insurance coverage, income, and disease prevalence of the general population. The status quo demand model assumes a continuation of current trends while accounting for demographic shifts of an aging population. And our reduced barrier scenario depicts what demand for services would look like if all individuals had access to services similar to the insured non-Hispanic white populations who live in metro areas. For supply modeling, we used Florida licensure data as the basis for determining our starting supply, and Florida-specific sources when available to determine various practice patterns, categorizations, and workforce characteristics. We hope that by having a detailed breakdown on these various inputs, it will help identify some of the causal factors around workforce shortages and can be used to mitigate current shortages or enact proactive policy to prevent future or worsening shortage conditions.
Clark and Patrick, thank you for your presentation. And to our audience, thank you for joining us today to review the methodology and key findings of our report, Florida Workforce Projections 2022-2037. This concludes today's session. If you have any questions, please feel free to send us an email at flcenterfornursing@usf.edu. Thank you for your engagement and investing your time to advance the future of healthcare in Florida.